And the second question was
incomplete. If the suction ring is okay,
Yeah.
but if the blade stops halfway.
Yeah. So if blade stops halfway, most of the surgeons will recommend to abandon the surgery, because if we try to recut the flap at the same time, we may end up with a multi-level flaps. So it is better to abandon and maybe later on either resort to a surface ablation or try to cut a flap at a deeper level, or maybe better idea will be to resort a femtosecond laser where you are very sure of your depth of sort of leveler flap. So that is that's how I will go about it.
And the last one was the buttonhole.
Yeah, buttonhole will be again common in steeper cornea, because and if there is a suction is not very good, because once the suction pressure doesn't build up, there is a buckling of the cornea. Once there is a pass of keratome over the apex of the cornea, at that time buttonholing happens. So best thing will be not to panic again and just replace the flap. Many people will like to do a TRK at the same stitching, but the proper advice will be to again abandon the surgery and do a surface ablation at a later date. 3 months or 6 months.
6 months
down.
later, down the line.
Yeah.
So DLK guidelines for diagnosis and treatment. It's one of the most dreaded things in the post-operative period, commonly called as signs of Sahara.
Yeah. So DLK patient comes, dramatically, because he gets very good vision the next day, and within 2 days he comes back with a loss of vision. So you have to suspect that's the number one cause, and you don't have to think of anything else. And if you carefully look at the slit lamp, you will see some sort of, interface problem at the edges, and if it is more advanced, coming towards the center. So intensive steroids, and they would respond very well. If they come late, if they come at 1 month with a similar complaint, then you should think of pressure induced, like Dr. Saab said, and that's the differential diagnosis is very close. But the main thing is it will come after 1 month, because the treatment is diametrically opposite. Then you stop the steroid. So steroid has caused a pressure induced and fluid in the interface. Here there is inflammatory material in the interface. If it doesn't respond DLK to steroids, I would be in favor at the end to wash, because sometimes you wash it and it just comes back, so you can't keep lifting so often. So wait till the end, give it a little time, and then wash.
So cutoff would be a month and a half of steroid therapy, or even more.
Easily.
So the next question is, what are your post-operative medications of choice in a typical case?
Yeah, routinely, we have to put them on steroids. I will usually put them on steroids 4 to 6 times, depending on
Dexamethasone?
Yeah, I prefer dexamethasone. I don't prefer prednisolone, because it is usually a suspension, and the pressure raising propensity of prednisolone is more than dexamethasone. And many people will prefer chloromethalone or clotipret also of late, because these are soft steroids. But I usually prefer dexamethasone with a combination of 4th generation fluoroquinolone for 2 weeks time. Usually I stop these, and of course we have to give a DF substitute at least for 9 months to 1 year, because usually LASIK will induce dry eye, which usually recovers in 6 months time. But just in case we have to look for any dry eyes pre-operatively also. In those cases we have to add on other anti-inflammatory agents like cyclosporine.
So the controversy lies there only.
Yeah.
Which tear substitute?
So that is a sort of personal choice also, but of late we are using basically a combination of CMC and hyaluronate, 0.1% and 0.5% of carboxylate hydrocellulose, because CMC helps in regeneration of epithelium, and hyaluronate is a very good thixotropic agent, and it stays on the eye for much longer time. Comfort is much more than always.
So coming to again one of the post-op complication, so how to evaluate a patient with regression and then how to take it forward, and when do we label it as regression?
Yeah, so I think, so basically we want to differentiate from undercorrection.
Yes.
So undercorrection will be known immediately, within a week, or you would know there is undercorrection. And regression will take time. It will take at least weeks to months to come up, and much longer. So regression, I think, first thing is, if it is a small regression, I would counsel the patient and not do anything. And I think the problem starts in prevention in the beginning, of not promising zero to any patient of refractive surgery. Once you don't promise zero, small regressions here and there, you can always manage the patient more. I mean, once the expectations are not there. And of course, if it becomes significant and there's some reason that you have to do it, you have to lift the flap and do it maybe after 3 to 4 months at least of waiting. Yeah.
So epithelial ingrowth,
Yeah.
the classic signs to pick up for a beginner as a LASIK surgeon, and then when to manage it. It's depending upon the site and the amount of ingrowth.
So epithelial ingrowth is not a very common complication of LASIK. Of course, it becomes much more common if we are doing a relifting of the flap for any reason, like washing out this thing or doing these surgeries. And again, it can be classified into different grades, grade 1, 2, 3, 4. 4 will be where you have nests of cells even in the center of the cornea. So if they are in the center of the cornea affecting the vision, of course, then we have to treat it. There is no question that we should leave it like that. But if they are just restricted to the periphery, we have to observe it over a period of time. And many a time we have to see for any track of sort of fistless track between the flap and the rest of the cornea margin, going into the deeper into the cornea. By doing it, a very easy test can be done by staining the cornea with fluorescein, and after maybe 1 or 2 minutes, the fluorescein, you can see the fluorescein track going underneath it. So in that case, you have to cut off that source of epithelial ingrowth, otherwise it will never go away.
No.
In that case, you have to lift it and cut off that source, and of course, after scraping it off,
Debride it.
try to seal it with a different glue. But if it is an isolated nest, that too in the periphery, usually they die down and you don't need to treat
Do
them.
anything. So going on to one more common complaint from the patient, post-op LASIK glare. Any role of anti-glaucoma drops in that?
Yeah, I think that's a simple and good solution. So I think
Brimonidine.
can be given in the evening, maybe 4 o'clock, and that solves the problem.
Anything to add to that?
Yeah, because many patients will have difficulty in driving, especially again dawn dusk conditions at night time. So it's a good solution because that will lead to constriction of the pupil, but many people don't tolerate it. So maybe sometimes we have advocated switching on the dashboard light to make the pupil
You can.
constrict.
That's a good tip.
And maybe then there are other special type of spectacles also are available.
Amber color, does it help?
Not, it is a tiny light on the side,
Okay.
so they can also make the thing, because switching on the dashboard light also makes it driving a little bit difficult.
Hmm.
Yeah, so these are, but of course, Brinavani is a well tested, time tested
Yeah.
for this problem.